of the regulation to go over some of the basics and invite some of the players to listen in and give input. And a lot of them don't really want to do anything. Surprise, surprise. But so this invited the question of, well, who are they and who are the PBMs that are actually subject to this? And so I didn't know if, absent the final regulation being complete, I didn't know if you had a mechanism to compel specific entities, or if there are some that say, we're not subject to this, or, you know, I didn't know if you knew exactly who the entities are that are actually going to be compelled to participate.
Sure. So I think we are interested in aligning with the division as much as possible for that reason, because we know who the big five PBMs are, because we have a separate data stream where the health plans report to us which PBMs they use. But our understanding, and this is partially informed by your office, is that a lot of the functions of pharmacy benefit managers are being pushed out to different companies, so that the supply chain isn't as neat as sort of an easy flow. So there isn't a PBM might do some functions, and they might have a rebate aggregator or a different entity that does different functions. And so I think for that reason, we would want to use the same list, because otherwise I think if we stick to just the list of the PBMs that we know health plans worked with historically, that's going to be a narrower focus. So I think to answer your direct question, we certainly want to align with the division on that list of entities, because I think as a condition of licensure, they have to file with CHIA. So that's, I think, will certainly help us get the data from potentially reluctant submitters.
I'm wondering how much detail you're able to get into, because there are actually a finite number of PBMs. They're not even a huge number of health plans. There's a slightly larger number of pharmaceutical companies, but each of these relationships is huge. And I'm wondering, unless you can really follow the plumbing, just looking at things in aggregate, other than concluding that, well, these PBMs are very profitable, I don't know what we can learn with regard to opportunities to do anything. So let's just say a PBM is subject to a very large rebate from a manufacturing company, subject to a particular formulary placement. But it's all buried in numerous of these things aggregate together, unless you ask for very specific arrangements. So I don't know how we could, learn just by looking. So, transparency is never the end, it's the means, right? It's like, what are we trying to prevent is what is the question. And then whether the transparency is actually going to get us there. So this one, I think it's really important. The PBMs have been such a challenge, but the data collection is pretty tricky. So I'm curious how much detail you're going to be able to get into.
So I can speak to one thing that we have done is talk with a number of other states have already embarked on this type of collection. And the good news for us, and potentially not so good news for them, is they've run into a lot of challenges for at those very issues around how to follow the flow of funds among all these entities, especially if it's a more aggregated collection. And so we've been talking to these states about their lessons learned. And I think one consideration is, should we look at this at the claim level? Should we look at this at the drug, national drug code level, like even more granular at the most granular level you can get? And I think this is going to be a somewhat different collection for CHIA, because it's going to be both, data about expenditures and prices and utilization, but it's also going to be the formulary data that informs, this is the cost sharing design. This is subject to utilization management. And, obviously a PBM could offer like hundreds of options of formularies. So we have to decide how to prioritize, your biggest ones based on your mass residents. Those are sort of the decision points that we're we're wrestling with, and we could certainly invite any feedback that the council has around those types of issues. But yeah, I would say that's how to follow the plumbing is a great way of putting it. We've also been thinking about in talking to other states about even like org charts or, diagrams beyond just like our regular data sheets that we typically get. Another thing I would add is that the federal government has done some work in this area uncovering how some of these relationships function. So I think we'll look to that. And then our partners at the HPC have a whole office that I know will be looking at this too. And I think we will sort of like bi-directionally inform how we can better capture this. But that's why, just like with the hospitals and nursing facility related entities, we want to be as flexible as we can, because we're probably gonna learn a lot in year 1 and year 2. That's gonna make year 3 and year 4 data collection better and more actionable.
And if Alan has a comment or a follow-up
Yes.
on the third part, which is the Health Policy Commission, because you said to what end? And that's this new organization within your.
Yeah. Thank you, Faye. And we're excited to partner with CHIA on this as well. I think just to take a step back, the legislation that passed earlier this year really had a focus on beefing up 2 specific areas: market oversight, the role of private equity in healthcare, and the pharmaceutical sector, and understanding the plumbing, and what is driving the biggest, the fastest driving category of healthcare spending over the last, 4 or 5 years, 8-9% growth year over year, with no signal of betting into the future. And this has been an industry, both from the manufacturer side, wholesalers, PBMs, that has been incredibly opaque to policymakers, and sometimes purposefully so. And so this is a really, I think, important law and mandate for CHIA, for HPC, for the state government to tackle this issue and to be able to, with the information collected by CHIA for HPC, to be able to make thoughtful and considered policy recommendations. What do we want to change in our laws that may maximize potential value in this system and minimize areas that are not providing value to patients? And there are policy tools that other states have done. States have banned spread pricing. States have banned clawbacks. So there are things that states can do. And I think there are even more areas on the frontier about what are the policy responses to how we're seeing an industry that has a tremendous amount of revenue flowing through it. I would urge and support CHIA to take this mandate from the legislature and use it to be really comprehensive in thinking about the data that's being collected. Aggregated reporting is not going to be as useful as being able to deaggregate by PBM, by payer, understanding those relationships. What is the form of those? And we also know that some PBMs are owned by a larger company that owns the health plan, that are some of the biggest companies in the country. And so what are the relationships that they have with each other? How are they moving money back and forth? There are many PBMs that allege that they are 100% passing any rebates they get from the manufacturer back to the health plan, and that all of that is going back into reducing your premiums. Well, let's really understand if that's the case. Are there other mechanisms that are happening?
It's never the case.
So just to finish the thought, so like many things in which is, I think, just a strength of the Massachusetts structure here, she is doing the hard work of the data collection, and then we're going to be able to do the hard work of what do we make of this? How do we analyze this? What are the policy implications of what we find from that? And I think that's always been an incredible partnership between the 2 organizations. And so we have it's really designated a new Office of Pharmaceutical Policy and Analysis. We're going with OPA as the acronym for that. Some of you know this, and just to share that we have just recently hired a new director of that office, who is coming to us from the Federal Trade Commission, where he worked on investigations and market oversight of PBMs for the FTC.
Great. Alan.
So, these are early days. It's worth mentioning maybe that only Canada in small sectors has PBMs outside the US. Other countries don't have them, don't need them, because they do more useful direct things with and to drug makers. That said, we collect a lot of data, but we're the Center for Health Information Data and Analysis, and we've talked about the balance between the two. And I'm very concerned we may be embarking on a case of data poisoning. A lot of information, some of it certainly articulating with important matters under the purview of Health Policy Commission. But I think if we anticipate what questions we'd like to answer for ourselves with the data and what questions, of course, you'd like answered. So will we be able, 2 years from now, to say that one PBM does a better job in making a wide range of needed and effective meds available at lower prices? I don't think so. It may not be possible, but I'm not confident that the approach you've outlined takes us in that direction. I think if we start with questions we here and you would like to answer, that would help us get to a 3% annual growth in drug spending. Or whatever, with all effective meds available to patients who benefit from them. So if we have a list of, I'd love to see a list of questions at our next meeting. Questions we'd like to answer.
I think our previous conversation though about what is the flexibility and, you know, I mean, I think if, I don't know how many years ago, 5 years ago, were GLP-1s foreseen as being this sort of market disruptor that they've been? And so, yeah, I mean, I think you're right, but I also think there are questions that we don't even know yet, you know, that we're gonna need to ask in the future. So to maintain that flexibility in terms of how we're thinking about where this is going.
I think I'm also hearing another event. There are three groups that are working on this. I mean, we haven't done the DOI regulations, which is going to ask for a ton of data from those people, and they're not happy about it. And we don't want to ask for the same data, but we use it, and we want to know why we're asking questions. And you know, you're the big user on the why. So I'm assuming you all will talk to each other. Yes.
Yes.
I'm thinking about this. And then perhaps you can come back to us, actually update us and say, here's what we're thinking of, here's where it's going in terms of questions. Now I stopped you, said something.
No.
Well, somebody, oh, I'm sorry.
I was just gonna go back to the matter of PBMs being reluctant, unsurprisingly, to give us this data. Is this a matter of sort of different markets? Like, we're gonna have a much harder time in the self-insured market than we will with Medicaid in the individual market, in the small group?
I don't anticipate that because the way that so I guess I don't know yet. Certainly, we haven't embarked on the collection yet, but I think that one benefit is that they're submitting similar types of data to other states.
Okay.
So we are able to leverage, like I said earlier, some states' templates so that from their perspective, you know, it's the same type of information just cut by Massachusetts resident rather than Delaware, for example. I think the way that we've structured this type of data stream, because it's outside of the all payer claims database, we historically haven't had any issues with collecting self-insured. So we've been able to get kind of the full commercial market. I think it's going to be very interesting for Mass Health because, you know, Mass Health as a payer itself doesn't have a PBM, but the, you know, accountable care organizations, they work with PBMs. So I think the reluctance is probably, I mean, we haven't put out our specifications yet. And we anticipate working really, you know, sharing drafts with the data submitters and the other folks in sort of the industry. So we make sure people understand the instructions and it makes sense to them. I think it's because, I think I'm anticipating pushback because we are taking this kind of potentially broad view to be comprehensive.
Yeah.
But I do think it's the right strategy.
Yeah.
And I think with our three agencies plus, others working together, we'll be able to get the data that we're looking for.
Great. I just realized I have no idea if PBMs consider themselves covered by ERISA and like.
Yep.
We have an analysis of this, right? I think we have I should say a preliminary analysis. And I believe Robert is on the line, so keep me honest here, but my understanding is that an entity that meets the definition, so an entity that is contracted by a large employer that meets the definition of licensure under DOI, that is the entity, we're licensing the entity, we are collecting data from the licensed entity, not the employer that is contracted with them. And therefore, a risk does not apply. But I think our understanding is that there's different permutations of this. And so that's where things will get messy, but I think our preliminary analysis shows that ERISA should not block us from being able to collect information from the PBMs that are working with the self-insured employers.
Great.
I'm curious to what extent you've engaged payers in these discussions, given that they will be a primary end user.
Yes, absolutely. So we haven't started that yet, but that is certainly our intent. As I mentioned earlier, we currently collect from the health plans some information about the PBMs they contract with, what functions those PBMs serve. And I know they'll have a big interest in the data itself and making sure that CHIA is getting a comprehensive picture here. So yeah, absolutely, we plan to engage with the payers as well as, pharma manufacturers, PBMs. I think like consumer advocate organizations, I think we'll take a wide net in making sure that we're capturing the information that's going to be most useful to different players.
I also think there's a relationship between PBMs and pharmacies.
Yes, yeah.
And those arrangements that are also important to understand, that can impact independent pharmacies, retail pharmacies, and there have been state policy action in that area as well.
Recognizing we're just at the beginning of all of this, there will be a time that will come up. I think for some of us, it would be very helpful. One of the meetings, we just sort of did a chat.
Yeah.
Big clawback, and what do you mean with, how do rebates really work? And, we've seen the terms, but I got to, we don't know. And so that would be great to have it laid out first.
It may be helpful to be guided by a map of the sewers under Caras.
Yeah, and then doing it in terms of just like the really high level questions of like, how are they shifting costs to payers and how are they avoiding competition? It seems like those are like two really big questions.
And how much it differs between payers. In other words, did 32 Point negotiate very differently than Blue Cross, which negotiated differently than something else? And do they negotiate down what level? And so I think we're just beginning to peel the onion here.
And I think
Don't
that's.
cry while you're doing it.
We're very excited about this collection because like you said, I think there's a lot that can be here, but we need to balance that with the overload of data and making sure that we're collecting data that has like an intended use. And I will say that making sure the data quality is good is really front of mind for us. And we will benefit by the fact that these are national entities and they have submitted similar data to other states. So we will have some validation opportunities there between that and some of our other data streams like the all-payer claims database and our separate collection with health plans. But thank you for all of the discussion. This has been great.
No, thank you. Any other thoughts? Right on time. Great, good job. Chief priority areas.
Okay, you're with me, stuck with me again unless. Opening remarks.
Primary care and behavioral.
Great. So, as you probably know, earlier this month, we released updates to our primary care and behavioral health dashboards. So as a reminder to this group, the dashboards are really intended to be high level, but a cross-cutting view of the state of primary care and behavioral health in Massachusetts. To build these dashboards, we use both CHIA data sources as well as publicly available data sources and trusted data sources, and really create a compilation, bringing a lot of those data streams together in a single dashboard view. So I mentioned at our meeting last quarter that the primary care and behavioral health dashboards would have new data for 2023 that we released this month, and some new measures. So for today's update, I just want to highlight a few of the key findings here, but of course the dashboard and the data books, there's a lot more, there's many data points available on our website. So for primary care, you'll see on the slides here that we've added an indicator for each of the domains that we report on in our dashboard to suggest how we think things are trending. And I don't think you'll be surprised to see that in primary care, we're seeing a couple of positive signs, particularly around mass health, increasing investment in primary care, and some increases in residents who are getting preventative care visits. But on the whole, there's still a lot of concerning trends that we're seeing with the workforce. We see the proportion of PCPs leaving primary care increasing, and the proportion of medical school graduates going into primary care decreasing. I think another key finding that we're highlighting here that's important to note is that the proportion of residents who reported difficulty obtaining necessary healthcare increased across all racial and ethnic groups, particularly for Hispanic residents. So I would say on the whole, these findings continue to be concerning. Again, with the exception of Mass Health, we've seen investment based on they have a new primary care sub-capitation program that increases investment in primary care and provides advanced payments to primary care providers. Spending for commercial and Medicare covered members was flat, no change from last year. So if we move to the next slide.
Could I ask?
Yes, please do. Yep.
Maybe someone else has a question.
Yep.
When you say having difficulty obtaining necessary healthcare, is that primary healthcare or any healthcare?
I think we ask about, I don't know if we specify primary care or if it's just any necessary healthcare.
Maybe necessary. Yeah, it's from a return.
Yes, yeah.
I'm sorry, I didn't.
It's any necessary healthcare, not just primary care.
And then did we, and I should have looked, so my bad. Why? Is it cost? Is it a 2 week long wait period? Is it,
We do ask that, and it's typically due to cost.
okay, well, I'm gonna put my plea in to consider oral health a primary care, because it is mostly primary care and it is the #1 issue in terms of costs for consumers. 35% of the people who say they can't get care is because they're looking for dental care.
Mhm.
Docs are only 25% of people who say they can't. Hospitals are only 14%. It's primary care and the speech.
You know what, one thing
And I
that,
know you'd really be disappointed if I did.
we, we're starting to put together our updated specifications for this year, so instructions for the data collection. And we are adding some now oral health codes, like oral health delivered in the primary care setting, which I know is different than what you would receive in a dentist's office, but it's a small amount. But it's a start, I guess, is what I would say.
So you have a primary care, new task force, right, on primary care? Who's working on the new task force? Primary care task force?
Offices, but I'm not as involved as David, obviously, Chair.
Hi.
Hi.
you could put it on your agenda, because you've only had a couple meetings, so you're still at the beginning.
We're very much at the beginning, yes.
Thank you.
I just have one more quick question. Just wanted to clarify what, you term to be avoidable emergency department.
I'm sorry, I cut your ears.
Sorry, for the third, paragraph, what you consider to be avoidable emergency department visits. I just
Yeah,
want-
so,
Categories.
yep, so these are potentially avoidable emergency department visits. So this is when, in the survey, we ask folks like, did you need to go to the emergency department, for care that you could have received by a regular doctor? So this is from our survey of residents. So we don't know exactly which conditions we're talking about for this analysis. We do have another analysis that CHIA does that looks at potentially avoidable emergency department. That's not represented here. But this is self-reported based on sort of residents saying, I had to go to the ED because I couldn't find a usual source of care.
Is that, is it only ED and not, urgent care?
I think this question is specifically around emergency department visits, yes.
Alan,
I think the dashboard is very helpful, but how many primary care doctors and other capacity separate from dental do we need for 7 million people? How many full-time equivalents do we have? What could we do to narrow the gap? It strikes me that, as we've discussed from time to time, those are useful questions. And the dashboard provides further evidence, if we needed any, of how important those questions are. So I think if we could begin the job of writing down numbers, and I'd like to make this a specific request for today or for our next meeting, to come up with estimates of current capacity, primary care FTEs, MDDO and PA, and need, and the gap between them, along with an inventory of potentially effective steps to narrow the gap. Rinse and repeat for dental care. Same issue.
We released a report earlier this year, Alan, on, that does all of the counting, and documents many of the challenges. I think the question of need and how we project that into the future, I view that as a health planning question. And I'd be happy to come back at the next meeting and talk a little bit about what we've learned, what we're talking about at the primary care task force. A lot of interesting questions there.
thank you. It will be on the agenda.
So in addition to updating with a refresh of data periods for next cycle, the primary care task force that we've been talking about will be continuing to meet through the summer and fall. And I know we'll be issuing some recommendations around measures that are important to continue to monitor the primary care system. So I think we anticipate that the next cycle of our primary care dashboard will reflect many of the task force recommendations. But you know, we'd be happy I know we've had a number of conversations at this group about our primary care dashboard, but if folks have other ideas of measures we should consider including, we would love to get your input in that area, in addition to including the recommendations that we will be hearing from the task force later this spring.
You're doing behavioral health?
Yes. Keep going? Okay.
She always ends on time.
Okay. Behavioral health is so from a high level perspective, we released our behavioral health dashboard yesterday. So if you haven't had a chance to look at it, it's in your email from last week. Similar to primary care, we added a couple of new measures and refreshed the data for calendar year 2023. it's a slightly more mixed bag, I would say, for behavioral health with respect to findings. So, we did see that cost sharing for behavioral health services decreased for members with commercial insurance and Medicare Advantage plans. However, that's for services for which they used their insurance to access behavioral health. In another data stream, we found that 15% of residents reported paying the entire cost of their most recent mental health visit wholly out of pocket.
Do you ask why?
Let me phone a friend again for that question.
No, not currently, it's on the survey.
It has to be out of network.
Survey space.
It has to be out of provider network.
Well, I mean, I do wonder, because, you know, the assumption then is, oh, well, they don't have, right, it's out of network, they don't have coverage, et cetera. Part of, you know, are talking a lot about stigma is people who don't want to have a record.
Mhm.
You know, and it's obviously a lot better than it used to be. Like, you know, 30 years ago, nobody would want, you know, to have that out there. But so just wondering if there's any. I mean, I can't imagine it's a big percentage, but I do wonder if there is a piece of that for those who can. I mean, I guess is that considered a burden for everybody who's doing that, you know?
Yeah, I think we, you know, we do have means to potentially follow up the sizable group. And we do have a mechanism to potentially follow up after the meeting survey, but we can follow up on that.
Well, I don't know if it's an important enough question, but for me, it comes up as sort of, is it a confounding factor in that number?
Yeah.
I think it's potentially important, although, you know, this could be driven by many things. There is a proliferation of, you know, private, online
Yeah.
providers, because they provide these sort of really easy to access, zero quality control, almost predatory behavior. So that has really been catering to like teenagers and, you know, families that just do not know where to start. I don't know whether this is related, but I do think that that is something that we need to be watchful in some way, shape or form, because it could go in a very problematic direction.
Well, and my other question related to that then would be, and I can't remember because you have a lot of information you collect, but whether you talk to providers about why they're not signing up with plans, because as a social worker who's in like all these chat groups with social workers, they're like, it is not worth it. There are enough people who will pay out of pocket that I can't deal with the insurance, with the claims, with all of that. And so.
And I was just gonna add that nuance, that some of those patients that are paying out of pocket are those that have the ability to do so and are doing so to avoid the wait list.
Right.
So that creates equity.
Exactly.
Yeah, I think this is certainly one that we'll want to dig in on in looking at sort of the different types of data we have, from surveys to claims data, et cetera. But we were interested to see that there was a kind of divergent trend with the insurance coverage cost sharing declining, but then again, it could be people that are able to access care in a different format. So I think we'll be hopefully learning more about that through some of our other survey work. So
A quick follow-up question, I just want to
Yeah.
make sure I was clear, when it says without reimbursement, that means completely without reimbursement even after the fact?
yes,
Okay.
yeah, so even like they did not, you know, invoice their health insurance for it. Sorry, Emma, if you go back, I just want to quickly run through the other few findings here. So from a utilization perspective, we found that more than a quarter of residents in Massachusetts with commercial insurance had a prescription for a mental health condition in 2022, which was roughly the same number as in the prior period. So that's some stability there. We did find that the number of BH-related ED visits declined nearly 10% over the past year, which I think was a very positive finding. The average length of stay for these ED visits has also been declining. So that's an area, the only green arrow we were able to put on any of our dashboards this cycle. So that's certainly, there's some positive signs there. But again, looking at equity, we continue to find that the highest rate of families who did not receive behavioral health due to cost was among residents that identified as Hispanic.
On that third point,
Mhm.
do you think CBHCs are alleviating some of the pressure?
And certainly that's our hypothesis. We didn't pull the data out to look at, sort of specifically, but that's something that I would certainly like to look at and understand, what the volume looks like at CBHCs, that sort of at the same time period. I think that's a great recommended analysis.
The one-year data can bounce around.
Mhm.
Is it easy? I forget whether it's easy to look at 2, 3, 4, 5 years of data.
It is for some of the measures are only a few years old.
Sure.
And so, but for ones that we have a longer time period, that's what we typically put in our data book. So the spreadsheet that accompanies the dashboard. But I hear your point that maybe we can consider thinking about ways to include more years on the dashboard itself, because I agree, sometimes 1 year, it could be a blip, but we also are trying to make it easy for people to read. So there's balance there, but I think that's a great consideration for us too.
In this last bullet, Hispanic residents reported the highest rate of families who did not receive behavioral health care due to cost. Did you ask this whole question, or did you not receive behavioral health care, period? And then sub questions, is it cost or is it something else?
Yeah.
It's a follow-on as part of the MHAS. Did you forego behavioral health care at all? Necessary behavioral health care? If they say yes, then we give them some reason, tell us why. Is it cost? Is it lack of access? So it was sort of a two-part question to get to that finding.
Okay, so I haven't looked at the dashboard, so I have to go back and look at it. So did we continue to see a high rate of families saying they're not getting behavioral health care? Cost or not? Because I'm not sure, cost is very important, but cost may not be the only challenging factors. I continue to believe that a lot of people who need behavioral health care are not getting it at all. It could be due to all sorts of reasons. Cost is one of them, stigma is one of them, or just the systems. It's really difficult for people to get access to. Right?
We could follow up with that number, total families who reported not receiving behavioral health care.
Okay, I can look at the dashboard. Thank you.
Can I ask one more question? Just interested why it's only commercial insurance in the second one? Do you not have the number for?
I think we only, yes, I think we are focused on commercial in this key finding, but I would expect they would have the same number for Mass Health, but let me follow up with that. Yeah, no, we certainly should have the same information for the Medicaid, for the Mass Health population, and if we don't, we can pull that together.
Thank you. That was great. Yeah, 15 minutes for health out of the week. Yeah.
Thank you all for your time.
Yeah.
Hi there. I'm actually not able to turn on my video. It looks like the host has that disabled, but my name is Haley Farrar-Muir, and I'm going to be sharing some updates with you all today on some of the reporting products that we have developed to advance CHIA's 5-point equity strategy. CHIA has developed and published a static health equity dashboard that aggregates some of the previous reported findings to help to amplify and increase the impact of our existing inventory of health equity work, specifically related to the role of race and ethnicity. Can you all see me now?
Can we get no?
Oh, can you all see me and hear me okay?
Not.
Hear you okay?
Okay. As long as you can hear me, I think that's probably what counts. But certainly interrupt me if you can't. On this slide here, this is kind of an overview of the key findings that we've included in this dashboard that aggregates and sort of centralizes some of these findings that have appeared in our previously published work.
Sorry, one moment, Haley, we're just figuring
Trying
out.
to show you and then.
Oh, okay, great.
I believe everybody has a copy in front of them as well.
The
so,
speaker?
We can look at our pieces of paper.
Okay. All good to continue?
Yes.
Okay,
Sorry
perfect.
about
No problem at all. So yeah, just this dashboard really aggregates and centralizes some of the key equity findings from our previously published work in an effort to highlight some of the disparities that residents experience, particularly in these key domains that are listed here, which include health insurance, enrollment and coverage, the availability and access to healthcare services, utilization of healthcare services, cost and healthcare affordability to residents, provider finance and spending on healthcare services, and finally, quality of healthcare services. Next slide, please. So these are some screenshots of the layout of our static dashboard, just to sort of orient you a bit. Each page of the static dashboard defines and gives context to each one of the key domains that I just mentioned, and includes findings that are related to both race, ethnicity, and to region. As I mentioned, these findings are really sourced from a lot of the recent reporting that CHIA has done, and the types of sort of diverse findings that are included here are a reflection of the type of work that CHIA puts out, from our survey work to some of our spending-related analyses. And you'll notice that on all of the domains here, there is a connection back to the source material or the original publications that these findings were pulled from. In sort of addition to being able to aggregate findings to create sort of an ease of use for the user, this dashboard is really meant to describe and link out to the full products to encourage readers to dive more deeply into some of CHIA's reporting. So some of the findings that are highlighted here are related to coverage and access. And I think kind of the main takeaway point here is that Black and Hispanic residents sort of have disparate healthcare experiences in Massachusetts. These groups tend to have lower rates of employee-sponsored insurance. And in addition to that, fewer Hispanic residents had primary care providers. And multiracial residents were more likely to report difficulties when accessing care than white residents are. Additionally, from the regional component, we see that residents who live on the South Coast or in Metro Boston have more difficulty finding a doctor's office or a clinic that's accepting new patients. Next slide, please. These couple of images show the domain of utilization, healthcare utilization, and I think the takeaway here, again, is that Black and Hispanic residents tend to have disparate healthcare experiences, particularly when it comes to length of stay in acute care settings and the number of acute care revisits. Black patients in acute care settings tend to account for a greater share of inpatient discharges and emergency department visits relative to their share of the Massachusetts population. And from a regional perspective, we're seeing that folks who live in Western Massachusetts tend to have the highest acute care utilization per 100 residents compared to other regions. Next slide, please. Here we can see a look into affordability and finance. These are metrics that are really focused on the cost of healthcare services for residents and spending on healthcare services by payers and providers. Here on affordability, particularly Black and Hispanic residents tend to shoulder the burden of affordability issues, and communities that have higher proportions of Black and Hispanic residents tend to have lower spending on primary care and specialty care. Next slide, please. And then finally, here we have quality, which is metrics that are focused on sort of the standards or the value of care. This includes some new reporting that I'll share also on the next slide as well. But the takeaway here is that Asian patients tend to rate their primary care experiences lower than white patients do across the measures that are shown here, with the largest differences in access to timely appointments, responsiveness, behavioral health screening, and supporting managing health goals. So if we go to the next slide, I can share a little bit more on just sort of that last note. So CHIA has reported on statewide results of HEDIS clinical quality measures and MHQP patient experience survey results for several years. But for the first time this year, we have results for several of these measures that are stratified by race and ethnicity, which supports efforts to identify specific domains of care and opportunities to target initiatives to achieve a more equitable healthcare system. The report primarily focuses on care received in primary care settings, including measures of, for example, proportion of patients that receive preventative screenings according to clinical recommendations, or patients with chronic conditions that are well managed, as well as patient-reported satisfaction in domains such as communication with their providers and their ability to access care when needed. This report is at the hospital level. The Leapfrog Group is a nonprofit watchdog organization that sets the standards for hospital safety and quality, and in recent years has developed a healthcare equity standard with recommendations related to hospital collection of patient demographic data and the use of this data to identify these types of disparities. And so this report also includes information on hospital adherence to those healthcare equity standards. And this report we're expecting to publish later this summer. Next slide. So this is kind of our items for discussion. I know we sort of walked through those findings. And so our intention here is to update that dashboard that we showed you periodically as we sort of do some more targeted analyses and have more findings to include that have a health equity lens. And I think we're open to the council's feedback on ideas of what kind of metrics and measures or topical areas that we should consider including in future iterations of this. I think we landed on race and ethnicity and geography because CHIA has some pretty robust findings that are sort of spread throughout our reporting there. And so that's why we sort of focused our initial efforts to highlight those. But I think we're definitely interested in the council's feedback on how we could make this better in a future iteration.
Amy has a comment or question.
Yes, I'll start with a comment and then follow with a question. My comment is that as many people are aware, the Health Equity Compact is working on a statewide health equity benchmark. And I know CHIA has already been in conversations with the compact and would just encourage the continuation of those conversations to ensure maximum alignment. My question is, whether there might be room for outcomes to be included as a domain. And I recognize that I'm new to the council, so maybe this has been discussed previously. But as I was reviewing some recent CHIA reports, was really struck by, worsening maternal mortality, child mortality. And I'm sure there are certain populations that are being disproportionately impacted in those areas, and think those would be important kind of metrics to highlight on a health equity dashboard.
Yeah, I think that that's a really great point. Some of CHIA's work that we do now does focus on some types of clinical elements. I know in a lot of our case mix reporting, we do report out on top diagnosis codes that are associated with visits and the like. Healthcare outcomes, true outcomes, is not something that has, I don't think, been prominently featured in CHIA's reporting, but certainly it is part of the focus on equity. I know that AHEM is considering maternal mortality as one of their key areas, so it's certainly relevant.
Yeah, I think I was gonna say that I do think that AHEM in particular, looking at very specific, obviously just two categories in terms of maternal perinatal morbidity and mortality, as well as cardiometabolic health, has been collecting outcome data. And so I think we sort of have the set of data, which I know you've seen, that we've been putting out, but I think it's a conversation to continue thinking about what those could be. And how we make, what the alignment is between that data that we're collecting and what CHIA is doing. Andrea?
I have a slightly broader comment, which is also relevant to the provider dashboard and the primary care dashboard and the behavioral health dashboard, which is that Massachusetts doesn't operate in a vacuum as much as we might like it to. And there are a number of changes potentially on the horizon. And I think that as we're thinking about what metrics we want to be measuring, I don't have like the answers, but if we expect that restrictions on Medicaid provider taxes and state-directed payments are going to disproportionately impact primary care and behavioral health. What are the metrics that we need to be collecting to demonstrate that? I think is a conversation worth having, not necessarily in this moment, but sort of more broadly. Maybe that's something that the primary care task force is already working on. And sort of similarly, and more specific to the equity dashboard, I was thinking about the various policies that will limit access to affordable care for immigrant populations specifically. And so we have race, ethnicity. Is it possible to do more using immigration status? I'm not talking about legal, documented, undocumented, just is it possible to do more, or is that just a real data limitation we have? Because there's some real challenges that we're looking at both in Medicaid and the marketplaces for immigrant populations.
Haley, do you want to speak to what's included in the MHIS in terms of immigration status? Because we do collect some, but not all.
I know that citizenship has been an area of interest in some previous research briefs that CHIA has published using MHIS data. In terms of like having a great understanding of someone's status, I don't know that I can speak to the level of specificity that we can get there, but it certainly has been an interest that has actually made it into some of our key findings just around sort of who has access and who doesn't. And so it's certainly an area that we can continue to monitor sort of as policy changes may impact those communities now.
And I would add, I mean, I think the confounding factors are one that people may not even, is there a question about why do you not have access?
Right.
Well, because I'm too scared to go, the chilling effect.
Right.
And so there's measuring that, but then there's also, will people even answer surveys anymore? I mean, I feel like the data is all gonna become shakier, right, as these things eventually report.
I think this is great. Race and ethnicity are central. How about income? Is that possible? Is it worth doing? It may be worth looking at. It may give us a finer grained look. Also, when you reported on the different rates of hospital use by region, are those age adjusted?
So no, those are not age adjusted. That's the visit rate for that region per 100 residents, which is, it's a good point that it is not age adjusted. Yeah.
Certainly an impact on the Cape and Western Mass.
Yeah.
Mhm.
Yeah. Part of it.
I can answer in the family income question. So, sorry. Related to your first question about income, we do collect family income information, actually pretty comprehensive. And we do, standard reporting, in our MHIS report. And so for the dashboard, we certainly can look into for certain areas where we have family income information, we can add that layer. But it won't be universal for all the measures that we have included in the dashboard.
Thank you.
Okay, one thing.
The only other thing is rural versus urban. Could be a huge differences, but.
I second that. I was about to.
Surprised if you didn't mention that.
Yeah.
Haley, you're responsible for the workforce report as well?
That's correct.
Great, you're a minute.
All right.
Fortunately, it's one slide and it's fairly brief.
Awesome.
We have to get right on it.
Great. Yes. So just a quick update here about the 2025 Massachusetts Healthcare and Human Services survey. We're preparing to close across the 13 sectors that we have fielded the survey by the end of the month, June 30th. CHIA, its survey vendor, and provider association partners are all conducting sort of their final outreach to ensure that we have strong response rates across all of those sectors so that we can do the best reporting possible for our cross-sector results. After the survey closes at the end of the month, data is going to get cleaned. We're going to weight it and prepare it for analysis later this summer. True analysis will take place early this fall, and then current plans are to produce an updated dashboard similar to what we published in the 2023 cycle by January of 2026. We are looking at sort of making some enhancements to the dashboard where possible, especially based on some of the new questions that we've asked in this cycle. But we are excited to start to see data come in.
Great, thank you. If anybody has any questions or offers of additional thoughts, feel free to directly ask. We have a reached executive director's report.
Yes, we do have a lengthy, so I will try to be brief here. So since we last met in terms of the budget, the House and Senate have both passed each of their own budget proposals for fiscal year 2026. The next step is the two respective proposals will go to conference committee, and they will, in theory, reconcile their differences before July 1, the start of the fiscal year. The last time that's happened, I couldn't tell you.
14 years.
So we expect to have an FY 26 budget in place at some point this summer. I will say that the House budget level funds CHIA for 26. The Senate budget does provide for an increase, much of which is sort of reflects the new work that we have related to the market oversight and pharmacy legislation. I think we can manage in both scenarios, we will figure it out, but obviously the Senate version is the preferred route here. In terms of legislation, so as a refresh, we're in the first of a 2-year legislative session. We're continuing to monitor a number of bills that are relevant to CHIA. I think there's about 80 that directly sort of name or invoke CHIA specifically. Earlier this month, we submitted 2 mandated benefit reports, one on mobile integrated health providers and the other on community behavioral health centers. So those again are the reports that look at medical efficacy and cost analysis that and we go back to the legislature, and the legislature uses that information to decide whether they want to move those bills forward. We are also related to mandated benefits. We're also working on our retrospective mandated benefit review, which looks at all health benefit mandates that we currently have in effect in Massachusetts. And I believe we have the most of any states. And we do this sort of comprehensive review of the effects on costs, public health impacts, and a number of other qualitative analyses to help inform sort of the lay of the land. And I do think it informs the legislature's posture on additional mandated benefits, because I do think that one of the things the report highlights is the added cost of premiums of these mandated benefits. So CHIA does this once every 4 years, and we are currently working on that review and plan to release it later this calendar year. All right. All right, the EAPCD project. Since we last met, the project has hit a number of major milestones, which is exciting, and we are still on target to finish the project in September and plan to provide a demo to the council at the September meeting.
If that is true, we'll have a small celebration.
All right.
I know how much you guys have done. Yes.
Let the record show.
Let the record show. In September.
So a number of those, the key steps include loading the key data into the new environment. So really, this is loading all the medical, pharmacy, enrollment claims into the new environment. As notably as part of this process, the teams made improvements in the structure of the data about members' health insurance enrollment status, which has been one of the more complex and challenging aspects of this project. And the net effect is that the member enrollment data will be simpler to use for users and folks looking to analyze the data. I'd say the core of this project is around the groupers and enhancements, what we've been calling the flexible analytics. And this really is, these are really the tools to help users make meaning out of the data in the APCD. So we've now successfully implemented the tools. And again, this will allow users to identify service categories or examine spending and utilization by episodes of care. So I think that with these tools, these analytic tools, which truly are, as the name describes, allows for that flexibility, and it will allow users, whether it's internal CHIA team members or HPC staff, that will allow them to ask a number of different questions. So we are excited that the core part of this project, meaning the flexible analytics, has been successfully implemented. So we continue to make progress as we sort of are in our final sprint here. But again, are looking forward to presenting at the September meeting.
That will be
Any
awesome.
questions?
No.
There's a reason we're going on the record to commit this, so hell or high water.
If your multi-thousands project knows this is a big headline.
Might add a zero to the test. But yes, nonetheless, a lot of time, resources, but through sort of the early testing and implementation, I think it's really validated our decision to break ties with IBM and bring the solution in-house.
All right, it will have a bigger agenda item in September.
Yes, rather than being stuck in the ED report. So this next item is in response to a request from council members to really address and perhaps align on clarifying language with respect to the total and total healthcare expenditures, or how we talk about total healthcare expenditures. So currently, the current language that CHIA works off of is based on the statutory language. And we think it's important to use one singular definition to be able to track consistently over time and to measure performance against the benchmark. And that is data that is all sort of like, I would say, actual data reported by health plans. We recognize and understand that there are different definitions, including the federal CHIA definition, which I understand is in part based off of estimates. So I think there are some challenges being able to, both from a data reporting standpoint, but also the very nature itself, using actuals versus estimates, it makes it challenging to essentially like merge the two definitions. So what we would propose here is continue to use the current definition of total healthcare expenditures that we have been using, but aligning on language that would appear sort of in an asterisk on publications, external facing materials, our website, so that it really does call out the fact that our definition of THCE may understate spending levels in Massachusetts.
I think this is valuable. I would suggest, and really a good step forward. I think striking the word may, it would be important. I think it's unintentionally misleading. So if we say THCE understates total spending, and then at the next sentence, instead of specifically, how about, for example, it does not include. And I think your earlier language about how this is done by design would be very helpful to have right in here, that there's no intention to understate or deceive in any way, but it's to allow the comparison with the benchmark. and for other purposes. If that makes sense.
I'm not sure if in all contexts that it will understate, right? If you, depending on how you slice and dice, right? If you got down to a specific person who didn't necessarily have, do you think there are cases where there would not be?
I find it hard to think about how that would work for individual people, because it's a statewide tool.
Sure. Yeah.
A Medicaid enrollee who never buys an out-of-pocket prescription doesn't have a premium.
Yeah, 10% of the people use almost 80% of the healthcare resources.
Right. So when aggregated, I agree it does.
Yeah, I think that's right.
Yeah, okay.
Okay. So we'll take another pass at sort of modifying the language and we'll circulate so that there's.
And then people have a chance to read it, if they have any thoughts, send them along, as just getting 2 seconds to read it. Okay, we're gonna take our last couple minutes on the topic at hand. It's on cost care. This was pointed out in the auditor's report, we talked about it at the last meeting. That we have this cost care system, we have resources that are being spent on it, not being used. And it was brought up on, maybe we don't have to do it. It is required by the statute. So my thought is that we, as the council, not the executive director, the council says we suggest to the legislature, they take this out. And draft a letter which we would send around to the council members. So if you want to think about it and get back and have it as a bigger agenda item, happy to do that. Or if you're all in agreement, I will ask you, you're gonna have to raise your hands. Sorry. Do the hand lift one. What you think, and we ran out of time, and I really try to be on time, so I apologize. Thoughts, quick. Initial, sending a letter to the legislature saying, take it out. Trust me, it's not gonna happen overnight, but.
Well, it has to be typed. I think it's a great idea.
You know who to send it to? Or double check, or still send it to that.
Charlie Baker.
You can figure that out.
The relevant chairs,
If you can,
yeah, I would say relevant chairs.
you don't have to send it to everybody.
Yeah, leadership.
Do we have a crude sense of how much might need to be spent by CHIA or other entities to achieve some measurable improvement in the uselessness of the data?
Oh, are you having a better cost care compared thing?
And what might be done, what CHIA might be able to do with the money saved by avoiding all that wasted effort,
I think,
for example?
I think it's a different question to say, what are the resources that are currently dedicated to the website? And it's, I wouldn't say a whole team's worth, it's not that significant, but it is time and energy to update that every year for the statute. It's another question or calculation to say, what would the cost if we were to revamp and make it something different and that is more useful, what would that cost? I think so much of that, the answer to that question is dependent on what it is that we make it. But a lot of the crux of the auditor's report really talks about why aren't we marketing this more? Why aren't we doing sort of like a big campaign to the website? And I think that piece alone, if we were to really drive traffic to the website, the marketing campaign alone would be significant dollars to make it beautiful.
And I would think rather than addressing it from that direction, I think including the information we've talked about why it's so hard.
Yeah, right.
Yeah, why it is essentially,
Sure.
impossible to actually make it something better.
I believe it, I remember the marketing costs were high. It does take resources here. Since I believe it was passed, the health plans have to do a similar kind of one that is specific to what the benefits actually are of the person. So that takes care of a lot. So they're going there. So things have changed since it was designed.
I mean, I think it was a well-meaning policy at its time, and that time has passed. And investing any more resources into that is not useful when there are so many other more important things that CHIA could be doing in terms of actually providing information that helps policymakers, helps consumers, helps residents understand what's going on with their healthcare system. And I question whether there is any amount of money, even if I said I gave you $50 million, that you would make a website that would actually be able to provide what consumers want, which is how much am I gonna have to pay out of pocket for this healthcare service? And there's information that only the health plan has with regard to that. And where they are in their deductible, what their copay structure is, all of these things. We can aggregate, we can make averages, but that is gonna add additional confusion to consumers. If we were to drive people to that website, leading to more frustration, more confusion. And so very well-meaning. I think we all believe in transparency. We want consumers to have transparency and to make informed decisions, especially when it comes to costs. We just did a report about how deductibles are particularly problematic in terms of not being predictable, in terms of what patients pay out of pocket. I think our efforts, policy efforts, would be much greater used to talk about how we can improve cost sharing and the predictability and knowledge of cost sharing for consumers than on this antiquated and outdated policy mandate. My suggestion, I think you can gather where I'm coming down on terms of this, but I do think just ensuring that we're having some education with the legislators about some of these reasons, and perhaps following up with an official letter,
So
maybe an approach.
it'll be elegantly written, it will recognize that there's need with some information on it, and we will set the correct.
A small friendly amendment.
Sure.
The health plans themselves find it very hard to provide accurate information. Very hard, so much of the time. Unfriendly, but minor amendment. I don't think we want patients to be thinking about money. No other country asks them to. And very few patients are, I think, willing and able to do that effectively. So we may have an honest disagreement on that.
I'll take that as a friendly amendment.
Any other thoughts? Give about a minute or two if anybody has any burning thing, and please feel free to call or me if you have any more thoughts, because we sort of sprung it on you. Okay, I'm gonna take that as you're okay getting the draft. Because it will have our name as a council on it, not ours. Okay, do I hear a movement to request to adjourn? Just-
Yes.
Second.
Thank you. I'm